introduce Joanne Fitzgerald, as well as a very illustrious career in the health sector. She's also an excellent wingwoman. She's my fellow executive director at IHACPA, so I'm very pleased to introduce you to Joanne today. So Jo has worked at IHACPA since 2012 and currently holds the position of Executive Director, Policy and Classifications. Prior to this, she was Director of AR-DRG Development and was responsible for developing and managing the Australian Refined Diagnosis-Related Groups classification system. Joanne holds a degree in a Bachelor of Applied Science in Health Information Management from the University of Sydney. She has over 15 years' experience as a health information manager, working with health classifications in both the public and private sector. Joanne has worked as a clinical coder, manager of medical record departments, and at the New South Wales Ministry of Health. Please join me in welcoming Joanne.
Thanks very much, Sarah. And I have had a couple of Panadols, so thanks for the tip, Kathy. I'm not sure it'll help. I guess we'll judge at the evaluation time about how good my presentation was. So I'm going to talk today about IHACPA's latest classification, which quite fortuitously our chair, Shane Solomon, introduced yesterday, the Australian Political Party Classification, or as we call it, the APPC. We're releasing just in time for the election. I'm not going to talk about that, obviously. I quite like my job and I'd like to keep it. And I'm sure you also know that we would never release any national classification without doing extensive stakeholder consultation. We wouldn't spring it on you. We would have an advisory working group and we would have a public consultation and you'd all be able to rate it. What I am going to give you is an update on IHACPA's classification work. And I thought I would put a bit of a retro spin on it because I want to do it in the form of a round-robin letter. Some of you may not be aware of what a round-robin letter is. You may have to be of a certain age to have actually received one, and you may not have had the pleasure of receiving one. A round-robin letter is typically you would receive it in a Christmas card. It would be sent to multiple recipients, and the writer of that letter would describe, often in quite a lot of detail, what the family have been up to, their events, their activities, their achievements for the year. For example, little Johnny was made captain of the rugby team and Esmeralda was Ducks of her year for the 6th year in a row. And the family really enjoyed their skiing trip to St. Moritz, even though it's getting a bit pricey now. I guess before the days of social media, that was, how we were made to feel inferior about our lives. But fortunately, with social media, we can do that every day now with Facebook and Instagram. But my aim is not to make you feel inferior. My aim is to use the round-robin format because it's the first time that many of us really get together at these conferences. We haven't met since October 2017, and it's a great opportunity for us to be able to go through the classification family highlights since we last met in 2017. Some of you may not want to know our classification family highlights, but you are going to hear them anyway. Before we get started, let's meet the family. Oh. Sorry, I overdid the animations a bit there. If I run out of time, it'll be because of that slide. But here is the IHACPA family of classifications. And so we've got 6 work streams or 6 types of hospital activities, and we've got 8 classifications. But in true round-robin letter style, I'm not going to go through every family member. I'm choosing the ones that I'm going to showcase, not because the other ones are not good. We love all of our family equally. It's just that some of them, are more interesting. Some of them have also been touched on in previous sessions as well. Some of you might have seen Jenny and Susan's presentation on teaching and training, and subacute. We sort of are working on subacute, but we don't have things we want to showcase. And it's my round-robin letter, so I can choose the highlights. Let's start with the Australian Mental Health Care Classification, or as we call them, AMHCC. And AMHCC is a teenager, so what can I say about teenagers? A little bit volatile. Some days are good, some days put in a lot of work. Effort, guidance and support, I think AMHCC is going to come good. Now let's get into the serious stuff about the highlights. So just a reminder that we do actually currently have an ABF model for admitted mental health care. So that's currently priced using the acute care classification of AR-DRGs. And non-admitted health is currently still block funded. None of which of these scenarios are ideal in the long term, which is how the Australian Mental Health Care Classification, or AMHCC, came to be. And the AMHCC was implemented nationally in 2016. The AMHCC uses episode setting, phase of care, age, mental health legal status, and the consumer's symptom severity or functioning to assign episodes of mental health care. With the exception of this guy, phase of care, all of the variables were already collected in national mental health data collections, but phase of care is a new variable, or was a new variable, and it's a data item and in an activity unit, and it recognises that patients move through various stages of care as they move through a stage of mental illness, and as their care changes, the inputs and resources to their care changes, and that can happen within the one episode of care. So that's the concept behind phase. That's just a bit of a refresher of what the hierarchy of the classification looks like. So you can see there the basis of setting, phase, age groups, mental health legal status for admitted acute phases, and then the functioning or the symptom severity with HONOS and the LSP. So what's AMHCC been up to? AMHCC has been extremely busy. We've been doing a lot of things, and when I say we, it really is the royal we, because the first 3 dot points have actually been states and territories who have been doing all that work with AMHCC. Rolling out training and implementing the mental health phase of care in their health services. Also focusing on the other AMHCC variables. I did mention that they're already in national data collections, but there is variation. Obviously, HONOS completion is not 100%, LSP completion is not 100%. So there's also been a renewed focus on some of those variables, and we've been very fortunate with the support of AMACAN, for example, who do the National Outcomes and Case Mix collection, and they continue to support the work for those collections of those variables as well. And health services and states and territories have been looking at their costing system and the costing of mental health so that we can continue to progress the AMHCC. In terms of what IHACPA's been doing, we've been spending a lot of time assessing the new data item of mental health phase of care. Back in 2017, we did an inter-rater reliability study which showed that there was broad clinical support for the concept of phase, but that there was poor to fair inter-rater reliability. Some of the phases had better reliability, inter-rater reliability than others, such as the acute phase and assessment only. The challenges were generally between functional gain, intensive extended, and consolidating gain. And the conclusions of the report were that the poor to fair inter-rater reliability was to be expected for a new concept, that there was confusion about some of the labels and descriptions, but that also it was still a very new concept, and a lot of the participants in the study had not actually been trained in assigning phase of care, so that there was still a lot of work to do to get the concept embedded. And the report recommended that we needed to do further work to refine the phase of care to increase its consistent and accurate application. So that's what we've been doing more recently. In 2018, we engaged 6 mental health care clinicians to undertake a project to refine and improve the usability of the mental health phase of care tool. And we've called that the Mental Health Phase of Care Clinical Refinement Project. That project is close to reaching its conclusion, and the findings from the project indicated that the current definitions, so the current descriptions and the current definitions, they contain mixed concepts. For example, some were describing a type of care, some were describing expected consumer outcomes, such as functional gain, some were describing the consumer presentation, some, like intensive extended, was describing the duration of care and the intensity of care. And these mixed concepts were creating confusion, resulting in issues with the boundaries between when a patient transitions from one phase to another. Similar to the previous project though, there was still strong support that mental health phase of care was an appropriate way to represent consumer activity, that patients do move between phases, And the clinical advisors, after consulting with several hundred mental health clinicians, have proposed refinements to the mental health phase of care descriptions and definitions, and we've presented them quite recently to our mental health working group for their initial review. So AMHCC is still going to have a busy year coming up and be busy for some time to come. The first thing we're going to be doing is continue to review those refined phase of care definitions with our stakeholders. It will need quite considerable stakeholder review, and it's not going to be a quick decision about making refinements to the tool. It's something that we expect people still to be collecting the current tool for some time, and it's a matter of working with states and territories and clinicians about what is a reasonable time frame should the new refined definitions be supported. We've also continued to work very hard with jurisdictions to obtain the mental health cost data. So we're going really, really well on the activity data, and there has been quite a focus for the 2017-18 National Hospital Cost Data Collection submission to focus on getting mental health cost data at the phase level. Because obviously our number one priority is developing price weights for the AMHCC so that we can continue to progress towards ABF for mental health care. So this is just some preliminary analysis for the activity data for 2017-18. And so for the admitted setting, we've got about 70,000 records with a valid AMHCC class. And so when we talk about records, we're talking about phase level records. In community, we've got nearly 146,000. So that is really, really a first cut of the data, and it is going to improve as we work with jurisdictions to improve on linkage with the multiple data files of the phase level data, with the episode data, and with the service contact data. And obviously we're still in the process of looking at the 2017-18 cost data to link that back with activity. So that was the AMHCC. Our next family member, we move to the emergency care world. And emergency care, there's sort of a youngish member of the classification family. So we've got URGs and UDGs, but we also have a brand new baby. The ACC, very cute, very excited. But before we go to the new baby, let's not forget the older sibling. Done some good service for us. And the older siblings are the urgency-related groups and the urgency disposition groups. And these classifications use type of visit, episode end status, triage, and in the case of URGs, they use diagnosis as well to classify emergency presentations into N classes. We have been working for some time on a replacement for URGs and UDGs, largely because the variable, particularly of triage, is not clinically supported. Emergency care clinicians don't feel it's an appropriate measure of patient complexity. It's also not a variable that we have found in any international emergency department classifications. And URGs and UDGs are limited in their clinical utility because of the way they group triage and episode end status and their lack of patient diagnostic factors. So, as I said, we've been developing the new classification for some time. And 2019 is the official birth date of the Australian Emergency Care Classification. As I said, we call it the AECC. We can't pronounce that, so we'll have to spell it out as AECC. And the AECC uses principal diagnosis, episode end status, visit type, age, and transport mode. And you might be looking at those variables and think, well, with the exception of age and transport mode, that looks pretty similar to what we use for URGs and UDGs. And it's true. And it's also quite intentional because we wanted to develop the first version of the classification using variables that we already have in our national data collection. But when you look at the hierarchy of what the AECC looks like, and I know some of you may have seen quite a lot the detailed version with James Caddy and Jim Pearce with their presentations yesterday, and so you would have seen this slide. When you look at the hierarchy, you can see it is much more of a diagnosis clinical characteristics-based classification. AECC has 3 levels. The first level splits on, it essentially partitions emergency presentations with all other presentations, so the small number of did not waits or dead on arrival patients, they're separated into different N classes, and most presentations are grouped into the emergency presentations category. That emergency presentations category then goes down to level 2, where it's split into emergency department diagnosis categories. Emergency care diagnosis groups. And so these are broad diagnosis groups, groups of diagnoses or clinical pathways in emergency departments, and there's about 71 categories. So compared to the previous URGs, which had, I think it was about 28 major diagnostic blocks, we have significantly increased the number of those broad level diagnosis categories. And then many of the diagnosis categories go to a third level, so that they're split on complexity. And that complexity is described using a complexity score, and that complexity score uses variables of a diagnosis subcategory. It uses the age group, the triage category, the transport mode, and the episode end status to calculate the complexity score. So although variables like triage and episode end status are still in there, they're de-emphasised in the classification, and they help describe the different complexity levels rather than being the major variable through which emergency presentations are categorised and classified. The other advantage, and for some of you, you're probably looking at this and thinking that's looking quite similar to DRGs again, which is quite deliberate in terms of dividing up emergency presentations into diagnosis groups and then splitting on the basis of complexity. And our intention is in the future to look at other variables which contribute to complexity, hopefully long term take triage out of the complexity calculation, and look at other variables such as additional diagnoses, interventions, other patient characteristics to help explain that complexity so that we can take out the reliance on things like triage and episode end status. ACC is also going to have a busy year coming up. Our immediate priority is finalising the stakeholder review and consultation on the new classification. We have a final report which has gone to our advisory committees. We're also finalising an independent quality assurance of the statistical modelling of the ACC to make sure that's okay. And we've also been continuing our development work on the National Emergency Department Principal Diagnosis Shortlist. So this is a shortlist of ICD 10AM principal diagnoses which hospitals can use for national reporting of principal diagnoses. So we've recently updated that national shortlist to reflect ICD 10AM 11th edition, and it's recently been published on our website. Our further focus next year is production of the supporting materials and the education materials so that we can move on to implementation of the ACC. And we expect the ACC to mature very quickly because we already have the variables required for classification. So where we've had a longer timeframe for implementation of pricing for mental health and for teaching and training, with emergency care we already have the variables and we just need to reclassify them according to the new classification. So we are looking forward to assessing the data and considering price weights reasonably soon. Obviously there'll still be consultation on that in terms of what the timeframes for that will be. We also always make a commitment to continually review and refine our classifications. Obviously this is a new one, so we want a time for it to stabilise and we don't want to do anything immediately, but we also do want to communicate to our stakeholders what the plan is for continued development and refinement, as we would with any classification. Okay, last but not least, actually it's second last but not least, Tier 2 and non-admitted care. So Tier 2 is also a youngish member of our family. Looking at that photo there, you'd think, quite young, quite fun. No one ever said that about Tier 2, I can tell you. We've known that we've had to replace Tier 2 for a while. Tier 2's, doing okay, but we're having to grow a new non-admitted classification. And I will be upfront and saying that the new ANAC baby will be quite some time in gestation. It's going to be a lot longer than 9 months. But before we get to the birth of ANAC, let's just do a quick recap of Tier 2. Tier 2 classifies non-admitted patient service events into categories based on the clinic the patient attended. And those clinics are organised according to the nature of the service provided, so whether it was a procedure, whether it was a consultation, whether it was a diagnostic intervention, and the type and specialisation of the provider. And here's the graphical representation in terms of how the various groups and classes are broken up. And as I said, we've known for some time that Tier 2 is not going to be the one that we use for the long term, but it does have one major advantage, which is still very important to us now, is that it's a classification we can use with aggregate non-admitted patient data. To move to a new classification will require patient level, and we're not there in all states and territories yet. So the issues with Tier 2, obviously, as I said, it's great that we can use it with aggregate data. But that's also its great disadvantage because it's not about the patient at all. It's very provider-centric. It assumes that everyone who attends a clinic is similar and consumes a similar amount of resources, which we know is not the case. And it also is not very flexible in some of the future funding models that obviously we've talked a lot about at this conference today, and it doesn't necessarily provide the right incentives for things like multidisciplinary care or for provider substitution. So we're developing a new classification. And in order to do that, we need high quality cost data and patient clinical data. So that is what we're in the process of doing, rolling out a national costing study to collect these variables to inform the development of the Australian Non-Admitted Care Classification, or ANAC. And I should say not to be confused with the Australian National Aged Care Classification. It's going to be, quite challenging, that one. So the costing study, it's currently in the setup stage, and thank you to Health Policy Analysis as I've adapted their study slide here. We're currently in the setup stage. The activity and clinical data collection is going to be, there's going to be a 9-month period for that, which will be between October 2019 and June 2020. So data collection will be in the 19-20 financial year. And sites who participate will have a data collection period of up to 2 months for collecting what we're calling primary data or additional data that they would be required. Most clinics, we estimate, will only have to collect that primary data for up to 2 weeks. But it's likely, we're hoping, that sites will have multiple clinics within that 2-month period, so 2 weeks here and then move on to another clinic and 2 weeks here and the like. And we've also had a 6-month costing period from July to December 2020. So IHACPA does not undertake costing studies lightly. We have already done a non-admitted costing study back in 2012, which has been used as the basis for Tier 2 prices for a number of years. There's a few chuckles from people in the audience who may remember it. We've done a lot of costing studies since then. We've done the mental health costing study back in, that was 2014. We've done the ED costing study back in 2016. And we learn from each costing study, and each costing study is better than the one before. And one of the biggest lessons we've learned is about reasonable timeframes, which is why you might be looking at this and thinking, why is 2021 mentioned? We're only 2019. But in order to get good buy-in from the sites, to be reasonable with the data collection and to leave sufficient time for costing. I imagine there's still some people in costing going 6 months for costing. You have to be kidding. So we have tried to make the timeframes reasonable. The scope of the study is quite broad, as non-admitted care scope is quite broad. So we're looking at services provided in hospitals, in the community, and also in the patient's home. And that might be done through one-on-one consultations or through group sessions, individual clinicians or multidisciplinary teams. Also that done by technology such as telehealth or video or email or apps probably even these days for some sites. And it's going to collect data about whether the patient was present or not. So it will include things like case conferencing, but we also are collecting clinician time spent on patient activity where the patient is not necessarily present. The variables will focus on what's already in the national non-admitted data collections, but there will be some additional variables which we're calling the primary data collection, which will need to be captured for a very short period of time. And so these are, some of these are patient factors, such as the presenting condition, so why did the patient attend that particular outpatient service, interventions, so what was done to them while they were there, how long did clinicians spend with patients? What were the characteristics of the service provider, such as what was their presentation? What was their profession? What was their designation? What was their pay grade, if you like? Also, some data variables around there in terms of setting context. So was the non-admitted service related to an inpatient admission? Was it a one-off visit, or was it part of a longer-term episode of care? So it's quite a small number of additional data items. Most of the data will be already collected. So if a site collects the rehabilitation outcomes data, for example, or radiotherapy national minimum data set data, we would like to utilise that. We actually anticipate that much of the data is already in existing systems, so in EMRs or in existing systems, and if it can be extracted from that system, then we will do it. We do not expect clinicians to collect the same data twice. If they're already collecting it, we will be able to find a way to get it out of that system. If it is not already being collected by clinicians and there does need to be a short period of extra data collection, then we're providing technology options to support that. So that's a desktop application and also an app, because we are app developers now. So, we're really excited just having a costing study so we can develop an app. We're not really. So if sites do have to collect additional data, there will be options to make that as painless as possible. If you want to get involved, it's not too late. Quite fortuitously, we have our public consultation paper on the costing study design and the data collection, and that's currently out for public consultation, and you've got till the 24th of May. So if you would like further details or information, or you would like to contribute, then please have a look at that paper. At the moment, our consultants are currently doing the site feasibility assessments. We have 32 sites which have been nominated, and we're going through those feasibility assessments to assess whether they have the ability to participate. And the principle is inclusion, not exclusion. We're going to be working with sites to set up the study. We're obviously going to be doing the cost and activity data collection. And we're also just going to be keeping a watching brief on the data items collected as part of the study and think about how we might start to transition important items into national data collections. Okay, I really just have a couple of slides left, so I think I'm going okay for time. I just want to briefly touch on the acute care member of the family and AR-DRGs and its associated, I don't know, can I call them children? ICD-10-AM, ACCI and Australian coding standards. Because, they're quite a mature classification, quite self-sufficient, really proud, going out there, doing some international work, but there are some changes coming ahead. So when IHACPA was formed, we previously contracted out AR-DRG development and ICD-10 development. We made the decision in 2016 to do AR-DRG development in-house, and we are very close to releasing version 10. It's with health ministers currently for comment. So version 10 was the first version of the classification we've developed in-house. And we have also made the decision recently to bring in development of the Diseases and Interventions classification of ICD-10-AM, the Australian Classification of Health Interventions, and the Australian Coding Standards. So from July this year, we will have responsibility for all of those functions in terms of classification development, coding queries, education, managing that work program. So we are very, very excited about it. Our first piece of work is actually going to be doing a national consultation on what people want in the AR-DRG development and ICD-10-AM development. I think it's a good opportunity to sort of take stock of where we are, what's been delivered in the past, is that still what stakeholders need, and there's probably lots of improvements and efficiencies we can make. And thank you very much.